Assistant Chancellor Dr. Vikas Chandra, MGUMST, Vice Chancellor Dr. Achal Gulati, Pro Vice Chancellor Dr. M.D. Soni, Pro Vice Chancellor Dr. V.K. Kapoor, Principal and Dean Dr. M.D. Soni, MGMCH, Senior Faculty Members and dear students. I welcome you all to the 15th UGCR on epilepsy. We will be covering the anatomical, physiological and pharmacological aspects of epilepsy, followed by the classification, medical management and in view of surgical management of epilepsy. Chairpersons for the event are Dr. Gaurav Goel, Professor, Department of Neurology, Dr. Deepak Gupta, Professor, Department of General Medicine, and Dr. Pankaj Kumar Singh, Professor and Head, Department of Anatomy. I would now like to invite Dr. Balveen Singh, Assistant Professor, Department of Neurology, to give a brief introduction on epilepsy.
Good morning to all present. At the outset, I would like to thank the entire organizing team of UGCR for including epilepsy as a topic of discussion. It is encouraging, to see it being introduced so early in the medical training. It is a condition I work closely with every day, both in my clinics and in the epilepsy monitoring unit that we have at Mahatma. Why is it important? There are lots of nitty-gritties, it's extremely complicated, but today we are going to simplify it to the core. So, epilepsy is a disorder of excessive, abnormal, synchronous neuronal activity in the brain which manifests as seizures. But mind you, epilepsy is not just seizures. It is basically a brain condition with significant neurobiological, psychological and social implications. Where the seizure begins often tells us how the patient will present. So first session that you will attend is anatomy, and remember that anatomy writes the script, seizure just performs it. So anatomy, seizure arises from all the cerebral cortex. Seizures arising from temporal lobe will behave in a certain manner. Seizures arising from frontal lobe will behave in a certain manner. Seizures presenting from the occipital cortex will behave in a certain manner. So anatomy just writes the script. Seizure is going to perform it. So important to know about the anatomical aspect of it. Now speaking about pathophysiology and why is it important? It reflects an imbalance. Epilepsy is nothing, just an imbalance between an excitatory and inhibitory neurotransmission. So we have excitatory neurotransmitters in the form of glutamate. We have inhibitory neurotransmitters in the form of GABAs. We have loads and loads of channels. We have loads and loads of mutations, ATPase pumps, which are coordinating and maintaining this balance. So a disbalance between the two will lead to seizures. Why pathophysiology is important is, when it comes to the treatment of epilepsy, it is extremely important to know about the pathophysiology of that particular epilepsy syndrome. Because epilepsy is not just about giving drugs. Epilepsy nowadays is about precision medicines. You go down to the channel involved and you try to eradicate that itself. Epilepsy management doesn't stop at the medication itself. So as we go ahead, we'll see that roughly 1/3 of the patients, they don't get, the seizures don't stop even with good medications. And when medications fail, it's not the end, it's the beginning of precision care. So as a tertiary care center, we cater to all these patients who are drug resistant to epilepsy. So as future physicians, we will encounter epilepsy across various disciplines, not just medicine, in emergency rooms, in psychiatric wards, in surgical OTs, if you are going to be a pediatrician or a geriatrician. So beyond diagnosis and treatment, your role will also involve reducing the stigma, counseling families and promoting safety and quality of life. Just to give you a heads up, this is the number of people with epilepsy in India. 142 crores population, 1.2 CR is people with epilepsy. And drug resistant is somewhere around 36 lakhs. This was a systematic review that I did in 2022. And you can see that the treatment gap is somewhere around 71%. 71% treatment gap means that there are 100 people with epilepsy, just 30 people are being given the right amount of drug and the right choice of anti-seizure medicine. So the concept of anti-epileptics is completely washed off now. There is no drug called as anti-epileptic medication because we know that we are not stopping the epileptogenesis. So we like to call it as anti-seizure medication. We are just controlling the seizure. So curing epilepsy is one thing, treating seizure is another, and we need to keep these two aspects in mind. So without further ado, I would like to call the people from Department of Anatomy to further go ahead with the program. Thank you.
Honorable dignitaries, esteemed faculties and colleagues. We are representing the Department of Anatomy in the 15th undergraduate combined rounds on the topic Applied Anatomy of Epilepsy. This presentation is prepared by Anushka Sharma, Monish Singhal, Tarushi Sharma, Vanisha Goyal and I, Vanshita Agarwal, students of MBBS first year professional under the guidance of Dr. Pankaj Kumar Singh, Professor and Head, Department of Anatomy, and under the moderatorship of Dr. Manali Arora, Associate Professor, Department of Anatomy. The learning objectives are overview of epilepsy, cellular organization of cerebrum, classification of epilepsy, and functional anatomy of cerebrum. Let's start with understanding the basic definition of epilepsy. It is a long-term or chronic disease that causes repeated seizures due to abnormal electrical signals which are produced by damaged brain cells. Hence, it is also called a seizure disorder. Coming on seizures, they are sudden, uncontrollable surges of electrical activity in the brain during which the normal communication between brain cells is disrupted. The causes of epilepsy can range from lack of oxygen and low glucose levels in newborns to stroke and dementia in senior citizens. The symptoms of epilepsy include muscle jerks, aura, staring spells, body stiffness, and sensory changes. Seizures can be classified into number 1, partial or focal seizures which start in only one hemisphere of brain, and number 2, generalized seizures which affect both sides of the brain simultaneously. Partial seizures can be further categorized as simple partial seizures and complex partial seizures. The basic difference between these two lies in consciousness and awareness, where in simple partial seizures the consciousness is preserved, while in complex partial seizures the consciousness is impaired. The symptoms of Jacksonian march start in one small area and march or spread across a larger area of the body. Generalized seizures can be divided into tonic, clonic, myoclonic, atonic, and tonic-clonic and absent seizures. The whole concept of epilepsy revolves around the nervous system, which is composed of two components, number 1 neurons and number 2 neuroglia. The structure of neuron comprises of cell body or soma containing the nucleus and organelles, axons, dendrites, myelin sheath, which is a fatty insulating layer, nodes of Ranvier, which are gaps in the myelin sheath, axon terminals, and synapse. The 4 types of neuroglial cells are astrocytes, which are star-shaped cells in the central nervous system, oligodendrocytes, which produce myelin, microglia, which acts as the first line of defense in protecting the neural tissue, and ependymal cells lining the ventricles of the brain. Neuronal connections refer to the ways neurons communicate and link with each other to transmit signals in the nervous system. These connections form neural circuits that are fundamental to sensations, movements, thoughts, and emotions. Types of synaptic arrangements are exodendritic, in which axon of one neuron connects to the dendrite of another. This is the most common type. Next is exosomatic, in which axon of one neuron connects directly to the cell body or soma. Next is exoaxonic, in which axon of one neuron connects to the axon of another neuron. And lastly, dendrodendritic, in which dendrite of one neuron connects to the dendron of another neuron. It is seen in some specialized areas like the olfactory bulb. The cerebral cortex is divided into layers which are distinguished on the basis of type, density, and arrangement of cells. Starting with the molecular or plexiform layer, this is the most superficial layer and consists of a dense network of tangentially oriented nerve fibers. This layer also contains few horizontal cells of color. Next is the external granular layer. The axons of this layer enter the deeper layers while the dendrites terminate in the molecular layers. This layer shows 2 types of neurons, number 1 being small pyramidal cells and number 2 being stellate or granule cells. Number 3 is the external pyramidal layer. The axons of this layer form commissural and association fibers. This is followed by internal granular layer, which contains external band of bilarger or white stria, which is prominently marked in the visual cortex. The fifth layer is the ganglionic layer, which has stellate cells and cells of Martinotti scattered among the pyramidal cells of pets. This layer also contains some horizontal fibers, which form the internal band of bilarger. The last layer is the multiform layer, which is made up of polymorphic cells. Now that we have discussed an overview of epilepsy, we shall move on to the anatomical phase of it. Epilepsy is associated with anatomical changes in the hippocampus, amygdala, frontal cortex, temporal cortex, and olfactory cortex. The cerebrum, which is the largest part of the human brain, is sorted out into frontal lobe, parietal lobe, temporal lobe, and occipital lobe. Starting with the frontal lobe, it occupies the area anterior to the central sulcus and superior to the lateral sulcus. It is responsible for controlling voluntary movements, personality, mood, and higher intellect. The seizures of frontal lobe epilepsy are of short duration, often less than 30 seconds, and may occur frequently. Broca's area, which is a motor area, is usually located in the left inferior frontal gyrus and is primarily responsible for speech production and language processing. The frontal lobe is the most commonly involved brain region in epilepsy. The symptoms of frontal lobe epilepsy are loss of consciousness, weakness, inappropriate laughter, repetitive jerky movements, screaming, and personality changes. Moving on, the parietal lobe occupies the area posterior to the central sulcus and superior to the lateral sulcus. The seizures of parietal lobe epilepsy originate in the parietal cortex, which processes sensory information, spatial orientation, and body awareness. Moving on, the temporal lobe occupies the area inferior to the lateral sulcus. The seizures begin in one or both temporal lobes, which are involved in memory, emotions, language, and hearing. Wernicke's area, which is usually located in the posterior part of superior temporal gyrus, is a critical brain region involved in language comprehension. Temporal lobe epilepsy can be mesial, that is, from inner structures like hippocampus, or lateral, that is, from outer parts of the temporal lobe. The symptoms observed are auditory hallucinations, sudden emotional changes, dilated pupils, deja vu, confusion, and unusual posture. Hippocampus, which is a vital structure of the brain, is located in the deep temporal lobe of each hemisphere. It plays a central role in various cognitive and emotional functions. It is highly excitable and densely packed with neurons, making it more prone to generating abnormal electrical activity. Hence, it is the most epileptogenic part of the human cerebrum. A common pathological finding in hippocampal sclerosis in temporal lobe epilepsy is hippocampal sclerosis, which involves neuronal loss and scar tissue formation, medically known as gliosis, etc. Amygdala is a small almond-shaped cluster of nuclei located deep in the medial temporal lobe. It contains basolateral complex and central nucleus. It is associated with emotion processing and social behavior. In mesial temporal lobe epilepsy, seizures often originate in the amygdala. It has a low seizure threshold, meaning it is more susceptible to generating and propagating abnormal electrical activity. Olfactory cortex is found in the inferior part of the temporal lobe of the brain. It receives input from the olfactory tract. It is involved in the sense of smell or olfaction. A common warning symptom in temporal lobe epilepsy is a phantom smell, which is usually unpleasant, called olfactory hallucination or uncinate fit. The patients may report smelling something like burnt rubber, sulfur, or rotting matter. Moving on, the occipital lobe occupies the small area behind the parieto-occipital sulcus. The seizures of occipital lobe epilepsy originate in the occipital cortex. It is the least commonly involved brain region in epilepsy. The symptoms shown by the patients are hallucinations, eye pain, palinopsia, nose/blurred vision, nystagmus, and nausea. These are the references. Thank you everyone. Now I would like to call upon Ms. Mehar Mathur, representing the Department of Physiology.
Good morning
esteemed dignitaries, faculty members and colleagues. Today, under the guidance of Dr. Aparna Garg, Professor and Head Department of Physiology, and moderatorship of Dr. Sabir Hussain, Associate Professor, Department of Physiology, along with my teammates Harsh Sharma, Keshav Agarwal, Ruchin Sharma, Yashashwini Chaudhary, I am Mehar Mathur will be representing the Physiology Department by presenting on the topic Physiology of Neural Activity. The structure of the presentation was constructed around the following topics: structure of neuron, classification of nerve fibers, properties of nerve fibers, resting membrane potential and factors affecting its genesis, action potential, synapse and synaptic transmission, excitatory and inhibitory postsynaptic potentials, and lastly neurotransmitters. Discrepancies in normal neurophysiology, more specifically in the resting membrane potential, the action potential, the signal transmission and balance between excitatory and inhibitory neurotransmitters lead to the development of a neurological disorder known as epilepsy that manifests as recurring seizure. This presentation aims to understand the physiological foundations behind it, which shall be achieved by revisiting some primal physiological concepts. A neuron is the structural and functional unit of the nervous system that is entrusted with signal transmission across the body. It has three major components, which are the cell body, the dendrites, and the axons. The cell body, or the pericardion, hosts the nucleus along with a plethora of other cell organelles such as the distinctive missile granules and neural filaments. The dendrites are extensions of the soma that serve the purpose of information receiving and its subsequent transmission to the soma. The axon is also imparted the nomenclature of the axis cylinder. It originates from the axon hillock and it terminates into dilatations known as synaptic knobs that contain neurotransmitters. There are two main types of neurons that we will discuss. These are the unmyelinated and the myelinated types. The myelinated neurons have their axons covered by a sheath. This is known as the myelin sheath. The action potential jumps between the rods of front-tail in a process known as saltatory conduction. This serves to increase conduction velocity multifold. Various classifications exist to aid us in distinguishing the different types of nerve fibers. When physical properties such as fiber diameter and its consequent change in conduction velocity are considered, we resort to the classifications laid forth by Erlanger and Gasser on function. On this principle, nerve fibers are segregated into A, B, and C type that serve distinctive functions. When classification is made on the basis of susceptibility, it has clinical importance. Here, we check the susceptibility of different fibers to factors such as hypoxia, pressure, and local anesthetics. These are important in identifying the types of seizure and their localizations found in the brain. Certain typical attributes of nerve fibers aid us in understanding their physiological importance. These are known as the properties of nerve fibers. We have firstly excitability, or the response to changes in the environment that arise due to ionic disturbances. These can be either chemical, thermal, or electrical. These are largely dependent on the strength and duration of the stimulus as well as the extracellular calcium level. As epilepsy is mainly characterized as a state of hyperexcitability, this property has importance. Moving on to conductivity, which is basically the propagation of generated action potential. It is bifurcated twofold into orthodromic and antidromic type based on the direction of the propagation. Unfatigability lies on the principle that nerve fibers cannot be fatigued as they mainly conduct impulses that do not involve energy expenditure. Refractory period is also bifurcated twofold into absolute and relative refractory period. The former does not elicit any response to subsequent stimulus for a certain amount of time, and the latter only responds when the stimulus is of the suprathreshold category. The all-or-none law says that the action potential occurs with a constant amplitude and shape regardless of the stimulus being provided. And lastly, we have accommodation, which states that a continuous stimuli will decrease the excitability of the membrane potential due to a subsequent rise in it. Which brings us to our next question. What exactly is this threshold membrane? So the threshold membrane or the resting membrane potential is nothing but the difference in the potentials on both sides of the neuronal membrane, the inside and the outside. This is usually due to the distribution of ions that are unequal on either sides of the membrane. For a neuron, this value approximates to negative 70 millivolts. It is of importance to note that the membrane is, even though it is the equilibric state, the membrane isn't metabolically inactive. The factors that are affecting the resting membrane potential are the selective permeability, the Gibbs-Dolan effect, the Nernst equation, the Goldman equation, and lastly the sodium-potassium pump. We shall discuss each one individually. starting with the resting membrane potential, starting with the selective permeability, which is largely attributed to the presence of various ionic channels present throughout. These are twofold, the non-gated and the gated types. The non-gated channels or the leaky channels of sodium, potassium and chloride are present throughout the neuronal membrane. They are responsible for the maintenance of the electrochemical gradient as well as the genesis of local and graded responses. The gated channels include voltage-gated potassium and sodium channels that are concentrated at the Rolls-Royce wave, the voltage-gated calcium channels that are present at axon terminals, the mechanical gated channels that are involved in receptor potential and somatic sensory nerve endings, and we have the ligand gated channels that are predominantly present on dendrites. Moving on to the Gibbs-Donan effect, which we can understand from this model shown here. So this states that the activity of the diffusible ions such as the blue colored potassium and the orange colored chloride ions gets hampered by the presence of the non-diffusible large ions such as the protein molecules, which leads to the redistribution of molecules. However, at Gibbs-Donan equilibrium, there needs to be electrical neutrality on either sides of the semi-permeable membrane. Thus, we can infer that the ratio of the cationic and anionic ends on both sides shall be equated. When potential difference due to a singular ion needs to be calculated, we use the NURST model. And when the integrated role of all ions present across the membrane is required to approximate the value of the resting membrane potential, we use the mathematical model that was given forth by Goldman, Hodgkin and Gann. Now, resting membrane potential often varies due to osmotic variations that lead to its imbalance. This imbalance is ultimately neutralized by the presence of an ATP-driven pump known as the sodium-potassium pump. This pump effluxes 3 sodiums out of the cell for every 2 potassium ions that are influxed into the cell, which ultimately establishes a negative voltage inside the cell. Now, basics of action potential include impulse propagation across membranes. It is of importance to note that there are 3 phases that are the depolarization, the repolarization and the hyperpolarization phases. A local response is generated as a precursor to action potential. This is due to subthreshold stimulus that occurs in succession that ultimately leads to a net additive effect, ultimately reaching the value of the threshold stimulus. Once the threshold stimulus or the value of negative 55 millivolts is reached, the depolarization response begins, which is also classified into 3 phases: the rapid rising, the overshoot and the peak. The rapid rising phase is due to opening of a few amount of voltage-gated sodium channels that ultimately triggers the opening of a greater number of channels in a process known as the positive feedback or Hodgkin cycle of autoactivation. This causes an increment in the membrane permeability to sodium, which causes a large amount of influx that changes the membrane potential. When it exceeds the isopotential value, the process is known as overshoot and it ultimately reaches the peak, which occurs at positive 35 millivolts. It is at this value that there is closure of the inactivation gates of sodium, and due to this, the depolarizing forces finally become strong enough to bring forth the depolarizing response. This occurs due to opening of voltage-gated potassium channels, which effluxes potassium out of the cell in order to restore the membrane potential back to its normal value. Now, interestingly enough, these channels are stimulated at the same time as that of the sodium channels, but they take a longer time to open, and thus they remain in that open state for a prolonged amount of time, which leads to the hyperpolarizing wave. When transmission between 2 neurons is required, we have 2 mechanisms. These are the electrical and the chemical mechanisms. The electrical mechanisms are due to the presence of the electrical synapse, which is less common in the central nervous system. This occurs due to cytoplasmic adherence as well as the presence of gap junctions between the neurons that allow for bidirectional transmission of impulse. The chemical synapses that are more common in the central nervous system and more commonly affected in that situation have a characteristic unidimensional transmission due to the presence of a presynaptic terminal that secretes neurotransmitters and a postsynaptic terminal that consequently binds these neurotransmitters due to the presence of receptors. Neurotransmitters are described under 2 headings, namely the excitatory and the inhibitory headings, based on their chemical composition and the subsequent receptor to which they bind. Examples of excitatory neurotransmitters include glutamate, acetylcholine, epinephrine and norepinephrine, and examples of inhibitory neurotransmitters include GABA, serotonin, dopamine and glycine. The binding of the neurotransmitter leads to the genesis of either an excitatory postsynaptic potential or an inhibitory postsynaptic potential. Excitatory postsynaptic potential is due to depolarization that occurs as a result of increased sodium and calcium conductance and a decrement in the conductance of chloride and potassium ions. This leads to an increment in the membrane potential altogether. And the inhibitory postsynaptic potential is due to a hyperpolarizing response that occurs due to an increment in the conductivity of potassium and chloride and a decrement in sodium and calcium conductivity across the membranes that result in a decrement in the membrane potential. It is also of interest to note that there are changes in the postsynaptic neuron that supplement the genesis of a post and of the excitatory postsynaptic and inhibitory postsynaptic potentials. As discussed before, two main neurotransmitters present in the central nervous system are the glutamate and the GABA. We shall discuss each one individually. So glutamate is the main excitatory neurotransmitter in the brain, which is responsible for 75% of the excitatory transmission. It does this via the aids of two receptors. These are the ionotropic receptors and the metabotropic receptors. The ionotropic receptors are the ligand-gated receptors that showcase a rapid response. And metabotropic receptors are essentially G-protein coupled receptors that use signal transduction mechanisms to allow for G-protein signaling cascades, which provides a slow but prolonged response. Next we have the GABA or the gamma aminobutyric acid, which is the primary inhibitory neurotransmitter in the central nervous system. It also works via the aid of two receptors, namely the GABA-A or the ionotropic receptors that have a rapid response and the GABA-B or metabotropic receptors that have a slow but prolonged response. Hyperactivity in the glutamate and a deficiency present in the GABA is what manifests as epileptic conditions. The crux of the presentation was to understand that a state of equilibrium between homeostatic balance, excitatory signals and inhibitory signals is what keeps a neuronal membrane healthy, and any discrepancies in either of the factors is what leads to the manifestations of symptoms resembling that of epilepsy. These are the references. Thank you. Now I would like to call Ms. Nidhi Rathor from the Department of Pharmacology.
Good morning to all the esteemed dignitaries, faculty members and my fellow colleagues. My name is Nidhi Rathor and I am here to present on the topic, the pharmacotherapy of epilepsy. This presentation was prepared by my batchmates Kanishka Gehlot, Nikhil Gadesra, Palak Sharma and Tanvi Sonkar under the excellent guidance of Dr. Anusha Vora Ma'am, Professor and Head of the Department of Pharmacology, and the moderatorship of Dr. Pushkar Mani sir. Here's an overview of the presentation as we were discussing about the goals and principles of pharmacotherapy, the classification of anti-epileptic drugs and their mechanism of action, AEDs for different types of seizures and their adverse effect along with drug interactions, status epilepticus, therapy for special population, emerging therapies, and lastly some key takeaways for clinicians. The goals of pharmacotherapy is to achieve complete seizure control with minimal adverse effects along with avoiding long-term complications and improving the quality of life of the patient. The principles are to start with monotherapy, individualized treatment according to seizure type, age, comorbidities and drug interactions, monitoring the response and side effects along with regular clinical and lab monitoring, adjustment for special populations like in elderly, children and pregnancy, use therapeutic drug monitoring as and when indicated. The classification of anti-epileptic drugs on the basis of clinical use. Anti-epileptic drugs can be divided into two categories, broad-spectrum AEDs and narrow-spectrum AEDs. Broad-spectrum AEDs, as the name suggests, are effective against multiple seizure types, which includes drugs like valproate, lamotrigine, levetiracetam, and topiramate. Narrow-spectrum AEDs are effective only against specific seizure types, which includes drugs like carbamazepine, phenytoin, and gabapentin. On the basis of mechanism of action, AEDs can be classified into 5 categories: GABA enhancers, calcium channel blockers, glutamate inhibitors, sodium channel blockers, and drugs acting through multiple mechanisms. GABA enhancers enhance the GABA activity, which is an inhibitory neurotransmitter. Drugs like gabapentin, pregabalin, tiagabin, gabapentin, phenobarbital, and benzodiazepines act through this mechanism. Calcium channel blockers block voltage-gated T-type calcium channels, reducing the neuronal excitability, an example of which is ethosuximide. Glutamate inhibitors inhibit glutamate activity, which is an excitatory neurotransmitter. Perampanel blocks the AMPA receptor, while felbamate blocks the NMDA receptor, both of which are present in the postsynaptic terminal of the glutamate neuron. Sodium channel blockers cause blockage of voltage-gated sodium channels, reducing the neuronal excitability. Drugs like carbamazepine, phenytoin, and lamotrigine are sodium channel blockers. Drugs acting through multiple mechanisms are sodium channel blockers, GABA enhancers, potassium channel openers, synaptic recycle 2A protein binding agents, etc. Valproate and levetiracetam are the example of drugs acting through multiple mechanisms. Here is the mechanism of action of anti-epileptic drugs. As you can see, this is an excitatory synapse where glutamate is the neurotransmitter, and on the other side is an inhibitory synapse where GABA is the neurotransmitter. On the presynaptic terminal of the glutamate neuron, drugs like phenytoin, carbamazepine, lamotrigine, locazimide, zonisamide, oxcarbazepine block the voltage-gated sodium channel, which keeps prolonged inactivation of the sodium channel, causing inhibition of the high-frequency abnormal discharges with minimal effect on normal low-frequency discharges. Drugs like reticabin bind to the potassium channel and blocks the efflux of potassium. Drugs like gabapentin and pregabalin block the calcium channel and causes inhibition of the influx of calcium, thus stabilizing the membrane. Drugs like levetiracetam bind to the SV2A protein, thus modulating glutamate release. On the postsynaptic membrane, there are two receptors, the NMDA receptor and AMPA receptor for glutamate, which are blocked by felbamate and perampanel respectively. On the other side, GABA, which is broken down into succinic semialdehyde by GABA transaminase enzyme. This enzyme is inhibited by gabapentin, thus increasing the amount of GABA. Drug like tiagabin blocks the GAT1 channel, which inhibits the reuptake of GABA into the presynaptic neuron and the astrocyte, thus increasing its amount in the synapse. On the postsynaptic neuron, there are two receptors, the extrasynaptic GABA receptor and the synaptic GABA receptor. Drugs like benzodiazepine, which increase the frequency with which these chloride channels remain open, while barbiturates like phenobarbital increase the duration for which these chloride channels remain open, both of which ultimately increase the GABA chloride current. Moving on to the drug of choice for various types of epilepsies. For focal partial seizures, carbamazepine is the drug of choice, while lamotrigine, levetiracetam, and oxcarbazepine can be used as alternatives. For generalized tonic-clonic seizures, valproate is the drug of choice, while lamotrigine and topiramate can be used as alternatives. For absence seizures, drug of choice again is valproate, while ethosuximide is an alternative. For myoclonic seizures, valproate is the drug of choice, while levetiracetam and topiramate can be used as alternatives. For atonic seizures, first line of drug is valproate, while rufinamide and lamotrigine are used as alternatives. For status epilepticus, in acute condition, lorazepam is used, after which phenytoin and fosphenytoin can be used. Alternatives used are midazolam, levetiracetam, and phenobarbital. For infantile spasms or West syndrome, ACTH or vigabatrin is the drug of choice, while vigabatrin is preferred in tuberous sclerosis. For Lennox-Gastaut syndrome, valproate is the drug of choice. Lamotrigine, rufinamide, and cannabidiol, which is FDA approved, can be used as alternatives. The adverse effect of antiepileptics. Sodium channel blockers cause ataxia, dizziness, and diplopia. Phenytoin can cause gingival hyperplasia, histuritism, osteomalacia, megaloblastic anemia, and fetal Harrington syndrome. Carbamazepine can cause aplastic anemia, hyponatremia, and rash. while lamotrigine can cause Stevens-Johnson syndrome, although the side effect is dose-dependent. Locosamide can cause prolongation of the ER interval. Calcium channel blockers like ethosuximide cause GI irritation, headache, fatigue, and SLE-like syndrome. GABA enhancers can cause sedation, cognitive impairment, tolerance, dependence, and withdrawal syndromes, which are especially common with benzodiazepines and barbiturates. Valproate can cause hepatotoxicity, weight gain, tremor, and teratogenicity. Vigabatrin can cause permanent visual field loss. Glutamate blockers, which are AMPA or NMDA antagonists, are topiramate, which can cause cognitive slowing, kidney stones, weight loss, while felbamate can cause aplastic anemia and liver failure. Perampanel can cause behavioral changes like aggression and irritability. Here are the drug interactions of antiepileptics. Phenytoin, which is an enzyme inducer, can cause oral contraceptive failure, while it can also decrease the efficacy of warfarin and steroids. Carbamazepine, which is again an enzyme inducer, decreases the levels of other antiepileptic drugs and can also cause oral contraceptive failure. Phenobarbital is an enzyme inducer which decreases the efficacy of many drugs and also causes sedation. Valproate is an enzyme inhibitor which increases lamotrigine levels in the plasma and can cause risk of Stevens-Johnson syndrome. Lamotrigine, which is not included in any kind of drug interactions, can have increased toxicity if given with valproate. Levetiracetam has no major interaction and is safe with most of the drugs. Therapy for status epilepticus. The primary treatment would be maintenance of airway, normal blood pressure, fluid and electrolyte balance. A dextrose injection intravenously can be given so as to correct seizure due to hypoglycemia. The first line drug to be given under 5 minutes is benzodiazepines, which is intravenous lorazepam, which is preferred due to its long CNS action, while diazepam, which can be given either intravenously or rectal, is used due to its rapid onset of action and shorter duration. Second line drugs to be used after 5 to 20 minutes are IV antiepileptics like fosphenytoin, which is preferred over phenytoin because it causes less venal irritation. Valproate can be given, which is especially useful in generalized seizures. Levetiracetam is used due to its fewer interactions and is well tolerated with most of the patients. Third line drug, which is used in refractory status epilepticus, after 20 to 40 minutes, the patient can be given a midazolam infusion or a propofol infusion for which monitoring is required for hypertension. Therapy for special populations. In pregnancy, valproate must be avoided because it's the most teratogenic antiepileptic drug. Lamotrigine and levetiracetam are preferred. In children, doses must be adjusted properly while monitoring for behavioral side effects and growth-related impacts. In elderly, well-tolerated antiepileptic drugs like lamotrigine and levetiracetam should be prescribed. Monotherapy is preferred over polytherapy. Here are some emerging therapies. In cenobamate enhances the GABA-A activity and is also a sodium channel blocker, which is used in focal seizures and is approved by FDA. Cannabidiol, which modulates multiple neurotransmitter systems, can be used in Dravet syndrome, Lennox-Gastaut syndrome, and tuberous sclerosis. Fenfluramine, which is a serotonin modulator, can be used in Dravet syndrome as it significantly reduces seizures. Here are some key takeaways for clinicians. Individualized treatment is always preferred as one size doesn't fit all, so considering patient-specific factors is important. Regular monitoring. Adjust doses based on clinical response and side effects. Track adherence and therapeutic levels if needed. As a clinician, you must always remember that we are lifelong learners and hence new therapies and updated guidelines continue to emerge. So one must stay current to provide optimal care to the patient. Patient education. Educate patients about their condition, treatment options and potential side effects. Thank you for your attention, and I would now like to call upon Ms. Ankisha Yadav from the Department of General Medicine.
morning, respected dignitaries, esteemed faculty members. Today I, Ankisha Yadav, along with my team members, Ananya, Rakshit, Aman and Shubhi, are here to give a presentation on the topic Classification, Clinical Presentation and Management of Epilepsy. This presentation was made under the guidance of Dr. Puneet Rajwani Sir, Professor Head of Department Medicine, and under the moderatorship of Dr. Ambika Tyagi Ma'am, Assistant Professor, Department of Medicine. The learning objective of the topic of epilepsy includes a comprehensive discussion under several key headings. These encompass the classification of epilepsy, its clinical features and various aspects of management, which includes investigation, immediate care, pharmacotherapy and lifestyle changes. Additionally, the topic of status epilepticus will be addressed. Introduction. A seizure is defined as a transient occurrence of signs and symptoms resulting from abnormal, excessive or synchronous neuronal activity in the brain. Epilepsy, on the other hand, refers to a condition characterized by ongoing risk of recurrent seizures, which is typically due to chronic underlying neurological process. Seizures are classified based on their onset into three main categories: generalized onset, focal onsets, and unknown onsets. Generalized onset seizures involve both hemispheres of the brain from beginning and includes motor onset types such as tonic, clonic, tonic-clonic, myoclonic, myoatonic, atonic, and epileptic spasm. They also includes non-motor absent seizures which can be typical, atypical or myoclonic. Focal onset seizures originates in one area of the brain and are further divided into motor and non-motor types. Motor onset focal seizures includes automatism, atonic, clonic, epileptic spasm, hyperkinetic, etc. Non-motor focal seizures includes automatic or autonomic, behavioral arrest, cognitive, etc. Unknown onset seizures are those where the beginning of the seizure is not observed or is uncleared. They can be present with a motor symptom such as tonic-clonic or with non-motor like behavioral arrest. Further proceeding towards the clinical features, focal seizures are characterized by a rapid spread of symptoms and are often involve blind staring and automatism. When the temporal lobe is involved, impaired awareness is common. Frontal lobe seizures may present with a bizarre behavior such as dystonic posturing, sleepwalking, frantic movements, and incoherent screamings. Tonic-clonic seizures may begin with an aura and are characterized by an initial stiffening phase, tonic, and followed by jerky movements, clonic. Breathing may temporarily stop, causing cyanosis, and the post-ictal phase includes confusion and drowsiness. Absent seizures typically begin in a childhood and involve brief lapses in awareness. They can occur 20 to 30 times in a day and often mistaken for daydreaming. Atonic seizures involve a sudden loss of muscle tone leading to fall with or without consciousness. Epileptic spasms are characterized by brief axial movements, muscle contractions that typically occurs in clusters and are most commonly seen in infancy. Tonic seizures involve sudden muscle stiffening and may be accompanied by a loss of awareness. Clonic seizures are marked by repetitive jerky movements and are similar to tonic-clonic seizure, but the initial tonic stiffening phase is absent. Myoclonic seizure consists of brief jerky movements that often occurs in clusters and can be triggered by fatigue, sleep deprivation, or alcohol withdrawal symptoms. Further, proceeding towards the investigation, all the patient experiencing a transient loss of consciousness should undergo a 12-lead ECG as an initial investigation. To identify potential structural lesions, Diagnostic tools such as EEG, electroencephalography, CT scan and MRI can be done. If metabolic disorders are suspected, tests including urea and electrolyte, blood glucose, serum calcium, serum magnesium and liver function tests can be done. In case where an infectious or inflammatory disease is considered, investigation should include a complete blood count, chest X-ray, CSF examination, serology test for syphilis, HIV and for the collagen diseases. Management of epilepsy is focused on 3 parameters including the immediate care, the drugs for the treatment and precautions to be followed. Immediate management of epilepsy involves several critical steps to ensure the safety and recovery of the affected individual. First, the person should be moved away from the danger to prevent any injury. Once the convulsions stop, they should be placed in a semi-prone position to help maintain an open airway. It is important to ensure the airway is clear but avoid inserting anything into the mouth. If the seizure lasts longer than 5 minutes, urgent medical attention must be sought. Additionally, the person should not be left alone until they have fully recovered. Management of seizure involves selecting appropriate antiepileptic drugs based on the seizure types and treatment line. For focal seizure, lamotrigine is considered the first-line drug. Second line includes carbamazepine, sodium valproate, while the third line includes gabapentin, phenytoin, etc. In generalized tonic-clonic seizures, first-line treatments are sodium valproate and levetiracetam. Second-line options are topiramate, ethosuximide, while the third-line drugs being phenytoin, acetazolamide, and etc. For absent seizure, ethosuximide is the first line of choice, followed by sodium valproate as second line. In myoclonic seizure, sodium valproate is used as a first line with levetiracetam and clonazepam as a second line and third line options. Drug administration in the management of epilepsy should begin with one first-line drug. It is recommended to start at a low dose, gradually increase the dose until the effective seizure control is achieved. If the first drug fails to control the seizure, a second-line drug should be introduced, ideally with a gradual withdrawal of the initial medication. Monitoring of the effectiveness and side effects of the therapy is essential throughout the treatment process. Precautions to be taken. Patients with epilepsy are advised to avoid activities that could endanger themselves or others. Such activities include prolonged cycle journeys, engaging in tasks near water bodies and driving, which should be approached with a great caution. These precautions help minimize the risk of the accidents in the events of seizure. Status epilepticus is the emergency condition which refers to the condition in which continuous seizures or repetitive discrete seizures accompanied by impaired consciousness during the interactive period. It typically lasts for 15 to 30 minutes. Status epilepticus is managed in a staged approach on the duration and response of the treatment. In the early stage, 5 to 30 minutes, initial treatment involves the administration of intravenous benzodiazepine followed by intravenous anti-seizure drugs. If seizure persists and the condition progressed and established for 30 minutes to 48 hours, then for generalized seizure, intravenous midazolam or intravenous propofol is administered. For focal seizure, IV anti-seizure drug is recommended. If seizure remains uncontrolled beyond 48 hours, in this stage, treatment includes the use of phenobarbital or thiopentane and other medications like lidocaine or verapamil or additional anesthetics like isoflurane or ketamine or alternative approach like surgery can be done. Thank you for your precious attention. Now, to deliver a talk on a role of surgical intervention in epilepsy, I invite Dr. Balveen Singh, Assistant Professor, Department of Neurology.
Right, I think that was a very good session, specifically from young people coming up and talking about epilepsy. Few things, critical analysis, don't take my words in a negative or a harsh way, but first is you need to keep yourself updated. So IADE classifications have changed. You have put in 2017 paper. 1 month prior just the classification has been updated. We need to keep ourselves always updated in the process of learning. Right, coming back, I would like to take a minute to highlight that at our center we are now approaching drug refractory epilepsy, and I am very proud and I am very humbled to say that we are the only center in the city who is catering the drug resistant epilepsy patients. For patients who fail to respond to 2 or more appropriate anti-seizure medicines. So at our center we have established, all thanks to Emeritus Professor Chairperson Sir, Dr. M.L. Swankar Sir, all thanks to Pro Vice Chancellor Sir, Dr. V.K. Kapoor Sir, and constant support from professors like Dr. Hemant Malhotra Sir, Dr. Pankaj Gupta Sir, and Dr. Tarun Sir. We have established a fully functional epilepsy monitoring units where the patients undergo long-term video EEG monitoring. We capture the seizure, we try to localize the seizure, and then this data is systematically reviewed in our multidisciplinary case conference meeting, which are attended by neurosurgeons, our neuroradiologists, our nuclear medicine experts, and our neuropathologists. We have integrated advanced MRI protocols, we are doing PET scans, we are doing SPECT scans for advanced treatment of epilepsy. In short, we are no longer accept drug resistance as a dead end. It is a signal to evaluate, personalize, and escalate the care appropriately. So what basically happens is, neurology per se is very simple. People just think that it is difficult. It is just plain simple maths. Clinical symptoms, anatomy. Seizures arising from temporal lobe, frontal lobe, symptomatic zone is different. Then EEG, if the EEG also arises from the same area, and your imaging is somewhere trying to tell you that some abnormality is there, maybe in the form of some structural pathologies like tumors, or maybe in the form of subtle abnormalities like a focal cortical dysplasia. So if your epileptogenic zone is in concordance with your EEG and clinical data, go ahead, take it out. Take it out and cure epilepsy. Make the patient seizure free only if he is drug resistant epilepsy. This is another thing that we are doing. This is an ECOG. So EEG is basically we are placing electrodes over the scalp. But right now during the surgeries intraoperatively we are placing the EEG electrodes straight away onto the brain surface area, and we are go gyrus by gyrus to help our neurosurgeons to decide upon the posterior aspect of the resection of the surgery. For example, sometimes our neurosurgeons, they take a wider resection and they stop at 3.5 centimeters. Then we put in an EEG at the next gyrus and we tell that no, this is still spiking. That means that this area might soon develop to be epileptogenesis and maybe take a different route. So the patient might not be seizure free. So they widen their resection according to this ECOG. This is how an ECOG looks like. It's simpler to read as compared to EEG because scalp dampens all the electrical activity, and ECOG you're straight away, recording from the brain area. Coming back to a very important thing called as video EEG. So at our center we are doing video EEG, and take it from me, video EEG is not just for epilepsy. It is to differentiate the mimics of epilepsy. So I have seen patients who just have panic attacks but being treated with anti-seizure medicines, who have acute dystonias but are treated with anti-seizure medicine. Best way is you get them inside a video EEG room, you capture the event, you look for an EEG correlate, you make a diagnosis first whether it is epilepsy or not. If epilepsy, try to come down to a conclusion what type of epilepsy syndrome. Then open up your books. All this physiology and everything matters a lot. You have sodium channel blockers, you have remembered the names, and I see prescriptions where 2 sodium channel blockers are given to the same patient. That is not appropriate dosage, that is not appropriate choice of anti-seizure medicine selection. So this is how a pre-surgical evaluation looks like. We have to come down to concordance. If everything makes sense, it is concordance. We are also doing some artificial intelligence integrated things at our centers, including hippocampal volumetry, texture analysis, thin section cuts, And nothing is possible without a team. We have an epilepsy conference team. We have radiologists and nuclear medicine people along with us, and definitely the Department of Neurology is always with us. So it takes patience to listen, but skills to pretend you are listening. Thank you so much.
Thank you, sir. I would now, before we proceed to the question and answer session, I would like to invite Dr. Seizures uncontrolled muscular movements that arises like epilepsy is a relatively broader term with a neurological disorder precursor to the seizures.
Anybody?
Seizures are basically the clinical manifestations of the epilepsy. Epilepsy is a abnormal neuronal activity, and the seizures can be physically appear on the body, or it can be appear on EEG as well.
Again, not a correct answer. Yes, please. You presented the epilepsy. Yes, please.
Sir, recurrent seizures known as epilepsy.
Yes, so it is the abnormal seizures are there. Eh? But if it is a single event or very rare event, then it is a seizure. Seizure means the abnormal CNS electrical activity, which may be or may not repeat. But the epilepsy will always be there. It is recurring phenomena. Getting my point? And most of the time, cause is not known. It is idiopathic, spontaneous. Getting my point? So big difference. सीजर के कोई दो एग्जाम्पल बताओ जो जिनमें कुछ ऑफेंडिंग हैबिट्स होती हैं या ऑफेंडिंग ड्रग्स होती हैं जिनको आप करेक्ट कर दो तो सीजर करेक्ट हो। एक कोई हैबिट बता दीजिए। अरे सिंड्रोम को छोड़ो, पहले काम कीजिए। What is the vitamin? Which vitamin are deficient in chronic alcoholic persons?
It's B1 thyroid.
B1 thyroid, very good. And pyridoxine. So these are two important things which are responsible for the seizure, may be responsible for the seizure. So if somebody is taking chronic alcoholic, if you ask them to leave and correct the thyroid, what are the other diseases which can occur because of the thyroid deficiency? Very syndrome सुना है? Yes. So thiamine and pyridoxine. किसी ड्रग का नाम बता सकते हो जिसका साइड इफेक्ट है B6 और pyridoxine deficiency? Very common. No. Isoniazid, which you are using in tuberculosis patients, and once you stop the isoniazid, you can correct the seizure. So they are not epilepsy patients. Mind it. Remember it. Okay? और जो फिजिकल आप समझिए, दो सिंपल एग्जांपल याद रहेगा सबको। एक ड्रग का मैंने बताया, कौन सी ड्रग? जो एंटी ट्यूबरकुलर ड्रग है, आइसोनाइजर। उसको पेशेंट कुछ ड्रग्स पे है, उसको आप स्टॉप कर देते हो तो सीजर करेक्ट हो जाए, वो एपिलेप्सी नहीं है। ठीक है। सिमिलरली अगर आप एल्कोहल ले रहे हो, क्रॉनिक एल्कोहल पेशेंट्स हो, थायमिन लेवल्स आप देखिए, पायरिडॉक्सिन लेवल्स देखिए, एल्कोहल को स्टॉप करिए, सीजर से स्टॉप हो जाएगा। दे आर नॉट एपिलेप्सी। ठीक है ना। और एपिलेप्सी में किस किस तरह के चेंजेस हो सकते हैं? आपसे मोटर ही बता रहे थे। व्हाट इज टॉनिक, व्हाट इज मायोक्लोनिक? दे आर ऑल मोटर। व्हाट आर द सेंसरी चेंजेस? एनीबॉडी? बोलो बेटा, बोलो। आप हमेशा सीजर को कैसे डिस्करेज करोगे? या एपिलेप्सी या सीजर, लेट्स से सीजर, ठीक है, कैसे डिस्क्राइब करोगे? देयर कैन बी मोटर एक्सप्रेशन, सेंसरी एक्सप्रेशन एंड साइकोमोटर एक्सप्रेशन, ठीक है ना? विच पार्ट इज अफेक्टेड ऑफ द ब्रेन, वेदर इट इज फ्रंटल लोब, फ्रंटल लोब में कौन कौन विच रेस्पॉन्सिबल फॉर फंक्शंस? टेम्पोरल में, ऑक्सीपिटल में, उसी तरह के आप सेंसरी परसेप्शंस आप एपिलेप्सी में जिसको ऑरा बोलते हैं, ठीक है, वो होगा। ऑक्सीपिटल है तो विजुअल होगा, यहाँ पे तो ऑडिटरी हो जाएगा, टेस्ट का हो जाएगा, ठीक है, ठीक है ना। और चारों को आप डिवाइड कर सकते हो सरकाई से। किसने एनाटॉमी प्रेजेंट किया था? वंशिता अग्रवाल। 4 लोग होते हैं ना, जिसको आप बताओ कौन कौन से सरकाई से डिवाइड करोगे? दोनों दो हेमिस्फीयर होते हैं, किससे जुड़े रहते हैं? फिर जनरलाइज सीजर, एक फोकल जो सीजर है वो जनरलाइज कैसे हो जाता है? कहाँ से पास हो रहा है?
से पास होकर फाइबर्स उसमें कमिश्नर फाइबर्स जो से कनेक्टेड होते हैं और उससे पास होकर
What is status epilepticus? क्लिनिकल ये बताएगा अनिष्का यादव, यू प्रेजेंट।
With a loss of consciousness, and it generally occurs for 50 to 30 minutes. And how it is managed? So
5 मिनट भी काफी है, 15 मिनट तो बहुत है। मतलब टोटल स्पाज्म हो गया पेशेंट को, टोनिक में क्या होगा?
muscular contractions and jerky movements.
जर्की मूवमेंट नहीं हुआ टोनिक, पहले स्पाज्म होगा, स्टिफनिंग। और पेशेंट उसमें कई बार क्राई करता है बहुत जोर से, क्यों करता है क्राई? कहाँ की मसल्स? रेस्पिरेटरी मसल्स, फोर्स, एवरीथिंग इज कॉन्ट्रैक्टेड, टोन, तो उसकी चीख निकल जाती है पेशेंट। और टोनिक और क्लोनिक है, क्लोनिक में जर्की है और टोनिक क्लोनिक में पूरा बॉडी स्टिफ हो जाएगी, तो बाद में जर्क होने लगेगी। एंड व्हाट इज द डिफरेंस इन क्लोनिक एंड मायोक्लोनिक? मसल स्पाज्म में दोनों होता है बेटा। ओनली वन हैंड, वन मसल, वन ग्रुप ऑफ मसल फोकल है। जैसे आप एकदम सडनली अनविलिंगली इस तरह से अपने हाथ में करता है या पैर को करता है, जो भी एरिया इन्वॉल्व है। कौन सा मोटर एरिया होता है ब्रेन में, कॉर्टेक्स में? ये चीज आपको आनी चाहिए। एंड व्हाट इज द डिफरेंस इन कन्वर्जेंस एंड सीजर्स? ये कॉमन चीज है, सीजर्स हैं, कन्वर्जेंस है, एपिलेप्सी है एंड हिस्टीरिया है। आई विल कम टू हिस्टीरिया लेटर। Convergence are only motor representation, not the sensory or psychomotor representation. ठीक है कि नहीं? What is the hysteria? I am a gynecologist, हम हिस्ट्रोस्कोपी करते हैं, ठीक है ना? पहले जब शुरू में ये मिथ था कि लेडीज में ही यूट्रस वॉन्डरिंग करता है और हिस्टीरिया हिस्टेरिक हो जाती है, हिस्टेरिक हो गया है, that was given up. Now it is sort of absent seizures, functional movement disorder. It is a stigma sort of. इसमें कोई अगर आप EEG लोगे तो उसमें कोई एक्टिविटी नहीं आएगी। that is not epilepsy. You need to differentiate between hysteria and अच्छा pre-eclampsia या eclampsia में सीजर आता है तो उसको एपिलेप्सी बोल दोगे क्या? नहीं बोलोगे। तो समझ गए ना बेटा डिफरेंस क्या है? सीजर कोई ऑफेंडिंग कॉज होता है, whether that can be a metabolic cause, infective cause, traumatic cause, some malignancy or space occupying cause, ठीक है ना? वो होते हैं, या कोई विटामिन डेफिशिएंसी और कुछ डेफिशिएंसी, they are responsible for it. उस ऑफेंडिंग कॉज को हटा दोगे, पेशेंट करेक्ट। एपिलेप्सी में ऐसा नहीं है, एपिलेप्सी स्पॉन्टेनियस है, इडियोपैथिक है, और उसमें आपको बड़े डॉक्टर्स के साथ करेंगे, ठीक है? यहाँ पे आपको एक ड्रग, एक जो आपने इन्वेस्टिगेशन में अवॉइड का मतलब मिस कर रहे थे, एक आपने ड्रग दी फॉर एग्जाम्पल, ठीक है ना? ये फार्माकोलॉजी किसने प्रेजेंट किया था? मेहर ने। हाँ, कौन कौन से दो पाथवे बताए थे आपने? GABA is
an inhibitory neurotransmitter and glutamate is an excitatory neurotransmitter.
सारी ड्रग्स, ज्यादातर ड्रग्स इन्हीं दो पाथवेज पे डिपेंडेंट होते हैं। कई बार लोग क्या करते हैं कि एक ही पाथवे की ड्रग दे देते हैं। तो आपको जो ड्रग दी है उसके बाद भी कंट्रोल नहीं हो रहा है तो उस ड्रग के लेवल्स चेक करो सीरम, और ये जिसका डोज बढ़ाना है तो डोज बढ़ाओ। उसके बाद भी नहीं हो रहा तो फिर आप ग्लूटामेट पे जाओ, या ग्लूटामेट दे रहे हो तो गावा पे जाओ। गावा को आपको इंक्रीज करना है, ग्लूटामेट को आपको सप्रेस करना है, स्टिमुलेट। इन दोनों की कॉम्बिनेशन से नहीं हो रहा है तो फिर आप सर्जरी या बाकी ऑप्शंस में, ठीक है? इंपॉर्टेंट फंडामेंटल चीजें जो सब लोगों को आनी चाहिए। समझ में आ गया? एपिलेप्सी में, सीजर में, कभी सीजर इज नॉट एपिलेप्सी। एपिलेप्सी में सीजर होते हैं, बिल्कुल समझ में आ गया? हिस्टीरिया इज नॉट एपिलेप्सी। हिस्टीरिया एक अदर टाइप का डिसऑर्डर है, उसमें इजी कोई सेंट्रल एक्टिविटी, एबनॉर्मल इलेक्ट्रिकल एक्टिविटी नहीं होती। कन्वर्जेंस पे जैसे एपिलेप्सी में या सीजर्स में तीनों पार्ट इन्वॉल्व हो सकता है, मोटर इन्वॉल्व हो सकता है, सेंसरी इन्वॉल्व हो सकता है, साइकोमोटर इन्वॉल्व हो सकता है, पर कन्वर्जेंस में ओनली मोटर इन्वॉल्व मोस्ट ऑफ इट, थोड़ा और हो सकता है। फंडामेंटल चीजें बड़ा इंपॉर्टेंट टॉपिक है, बहुत लोग सफर करते हैं, स्टिग्मा है सोसाइटी में, आप सबको इसका ध्यान रखना चाहिए।
I think Sir has covered up most of the questions for you. Symptomatic seizures are different, epilepsy is different. 2 or more than 2 unprovoked seizures, 24 hours apart, or neurological syndrome is epilepsy. That's the main difference that you have to understand. So you don't have to treat first seizure like epilepsy. You have to find out the cause behind that first seizure. If you're able to find out the cause, you treat the cause. No need to treat seizures for a time.
Thank you, sir, for your valuable insights.
So जैसे आप अपना एप्रन पहन के और रोड पे जा रहे हो, वॉकिंग, वेटिंग फॉर योर उबर ओला, आपके सामने कोई somebody on the road falls on the road and starts having a seizure. So do you know what to do? Who will tell me what will you do? Yes, take a mic and say. So you know this apron can be a recognition also, and it can be a responsibility also. This happened to me when I was in the final MBBS. I did not know what to do. Tell us.
Sir, we recently encountered a case like that. Sir, actually, first you will take the person away from the crowd, and you will want everyone कि वो चुप हो जाए, मतलब हल्ला ना बचे पेशेंट के आसपास। दूसरा, पेशेंट को सेमी प्रोन पोजीशन में करेंगे ताकि उसका जो रेस्पिरेटरी और डाइजेस्टिव ट्रैक्ट है, ताकि उसको वॉमिटिंग ना हो और उसके रेस्पिरेटरी एयरवेज खुले रहें। तीसरा, मतलब हम जब तक पेशेंट के पास रहेंगे, जब तक एक तो उसके हैंड ड्रिपिंग करना है, और हम पेशेंट के जब तक पास रहेंगे जब तक वो नॉर्मल ना हो जाए, और अगर फिर भी 15 मिनट्स तक अगर कंटिन्यू रहता है तो हम पेशेंट को इमरजेंसी सर्विसेज में लेके जाएंगे।
Very good. So most important thing is take him or her away from the source of danger, and semi-prone. Why do you do semi-prone? Because if these patients vomit, then we'll aspirate them. So keep the airways clean and stay with the patient. Maybe you can't call it a patient. Stay with the person till full consciousness returns. Okay? Chappal sungaoge? Yes?